It's a pleasure again to be here and to speak on this topic. So what I'm going to try to address is really not the randomized control trials, but with the carbapenem resistance increasing among Enterobacterales, what do we know from multinational observational studies, and do they guide us in our therapy? These are my disclosures. And if we look at the trends in carbapenem resistance among Enterobacterales, and this is data from the century, from 20 years, looking at what has happened in terms of CRE rates in various parts of the world. And as you see here, Latin America tends to be a big problem. We see really a sharp increase in the rates, followed by Europe. North America is less of a problem, but I think this is variable depending on in which center you practice and what is the patient population where you practice. So this is from relatively older data, but the reason I chose this map is to show you that different parts of the world have different types of carbapenemases. So for example, KPC, Klebsiella pneumonia carbapenemase, is a problem in China, in North and South America. As you see, OXA48 tend to be more problematic in Africa, including South Africa, some countries in the Middle East, and Europe. And if we look at KPC CRE, this is data from 2013. Again, if we look at Australia, this was not a big problem. You have a dot in red to show that there were cases imported, but KPC was not endemic there. And this is from 2017, OXA48 distribution. And again, not a lot of data published. And when you have no color on the map, it doesn't mean that these carbapenemases are not present. It means that it has not been published yet. So this is data from Australia, from Victoria, and if we look at between 2012, 2016, there was a fluctuation in the predominant carbapenemases. 2014, for example, a peak of KPCs. 2016, there are now more Nudelli-metallobetalactamases, IMP, than KPC, but there are isolates that also produce Nudelli-metallobetalactamases as well as OXA. So as you see, NDM plus OXA at the same time. Now, COVID pandemic has really fueled the antimicrobial resistance, so we created a worsening pandemic of AMR within the COVID-19 pandemic. This is just one example from a New York hospital that really illustrate in a hospital that did not have problems with CRE prior to COVID-19. Post-COVID-19, they reported that 5% of their bloodstream infection and respiratory tract infections were due to Carbapenem Resistant Enterobacterales. And this is from a Center for Disease Control and Prevention report comparing 2019, 2020 to the years before. And as you see, although it says in green decrease, but in the on the far right, you see it says there was a hospital onset 35% increase. So I think, and the same applies to other multi-drug resistant pathogens, but we're focusing on CRE today. We also looked at our data. Patients with COVID-19 had over 1,600 patients hospitalized for COVID, and among those, 9.5% ended up developing respiratory tract infections. And if we look at the multi-drug resistant organisms, we had 25% of those, and among that, CRE made 13.8%. So really, it is a problem for us. Now, when we want to consider treatment strategies for improving patient outcome, obviously, we talk about stewardship. We want to give the right dose, the right route of administration, the right duration of antibiotic, because we want to improve patients' outcome and limit the unintended consequences of adverse events, but more importantly, emergence of resistance and C. diff. And now we have available to us a really novel antibiotics with very broad spectrum of coverage. And these are agents that we should really make use of and not just leave them on the shelf to consider using them only when we fail antibiotic therapy, because delay of appropriate therapy is going to be associated with mortality. And if we look at the drugs that have been available to us over the past 5 to 7 years, they have been studied in rigorous randomized clinical trials in various clinical settings, be it pneumonias, intra-abdominal infections, or some of the trials have been pathogen-directed trials, Carbapenem Resistant organism trials, such as the Credible trial, etc. But also, I think that what I want to cover in this presentation is more the real-world data and not the randomized controlled trials. I think if we look at how much CRE affects mortality in patients with severe infection, this is one example, retrospective analysis of over 40,000 patients with Enterobacterales. 3% of the patient had Carbapenem Resistant Enterobacterales. And when we compare CRE patient to Carbapenem susceptible Enterobacterales, obviously the outcome, as you expect, is much worse. Patients were 4-fold more likely to receive inappropriate empiric therapy when they had CRE. And so CRE was the strongest predictor of inappropriate therapy. So I like color codes because it makes it easier to make the point. So if we look at the drugs that became available over the past few years, the novel ones on the market, I think the ones that have activity against CRE are listed here. So green is active, orange is variable, red is not active. So as you see, Ceftazidime-avibactam, no activity whatsoever against CRE, whereas Ceftazidime-avibactam and Cefiderocol, they have activity against KPC and OXA48. Meropenem-vaborbactam, only KPC. And the other plazomycin and eravacycline also have activity against CRE. Plazomycin is now only recommended for urinary tract infections. And I think there is no really one best drug for everything. If we look at these drugs, each one of them has pros, has some limitations, and as we're faced with a patient to make a decision on treatment, we need to consider some of these factors that play a role in the decision. So just to go back, when I looked at what is the evidence on real-world evidence, not a lot has been published on many of the drugs listed here. The two that have publications are Meropenem-vaborbactam, very few studies, but a wealth of data is now emerging on Ceftazidime-avibactam real-world data. So this is going to be what I'll be presenting. So Meropenem-vaborbactam, I don't think it's available in many parts of the world, but this is a drug. Vaborbactam is a boronic acid beta-lactamase inhibitor. It does have potent ESBL activity against CTXM, SHV, and TEM, as well as KPC. And as I mentioned, no activity against OXA48 or NDM. And here you have the inhibition for the various enzymes. So it is a drug that can be used for KPC and ESBL Enterobacterales. And if we look at the mortality of CRE, historically, the mortality has been really reported to be high in the 40 to 50% range when older drugs were used, the extended meropenem, the colistin, and other drugs. And as we see here, the mortality now with the Meropenem-vaborbactam is 15.6%, which is quite good if we compare it to other data. So let me share with you this paper. So this is from Ryan Shields' group from University of Pittsburgh. It's, mind you, a single-center prospective cohort study looking at patients who received treatment for more than 72 hours. And 70% of the patients were in the ICU, 35% received continuous renal replacement therapy. So this was a sick patient population. And as you see, the clinical cure was seen in 65% with a 90% survival rate. Another from, Pittsburgh is a major solid organ transplant. It's probably the pioneer liver transplant center in the US, and they struggle a lot with these patients who end up developing recurrent Klebsiella pneumonia, bacteremia. This is just one case report, but it illustrates that Meropenem-vaborbactam might still have an activity even if the isolate becomes resistant to Ceftazidime-avibactam with an MIC of 128 microgram per ml. So this is a patient who received multiple drugs and failed to respond to the drug and was treated with Meropenem-vaborbactam, and which eradicated the infection, and they were able to retransplant the patient. But really, as I mentioned, the wealth of data on real-world evidence for CRE comes from Ceftazidime-avibactam. So you see here on this slide summarized the studies that have been reported. Some of them are single-center, other multi-center retrospective cohort studies. Some of them are prospective observational or multi-center prospective observational. And obviously, we don't have time to go over all of them. So I picked a few to illustrate a few points. So again, here a study from Pittsburgh looking at 109 patients with Carbapenem Resistant Klebsiella pneumonia, and 97% of the isolate harbored KPC, of which 76% had KPC2. And the patients were treated with either Ceftazidime-avibactam or Carbapenem plus aminoglycoside or Carbapenem plus colistin or other regimen. And basically, prior to the availability of the new drugs, this is what we used to treat these patients. And if we look at the clinical success defined at 30 days by survival, resolution of signs and symptoms, and sterilization of the blood culture with absence of recurrent infection, patient treated with Ceftazidime-avibactam had 86% clinical success. And this was much higher than the three other regimens they looked at. And by multivariate analysis of factors associated with clinical success at 30 days, treatment with Ceftazidime-avibactam was an independent factor for a good outcome with a significant p-value. Let's look at this other study, also from Pittsburgh, and the importance of this study is, again, it's a retrospective study, 77 patients, but 26% of their patients were transplant recipients, and these tend to be very sick patients, and the median Souha score was 5. Majority were Klebsiella patients, some equally and Enterobacterales, and Enterobacter. And if we look at the outcome, the 30 and 90-day survival rates were 81% and 69% respectively. And when they did multivariate analysis, pneumonia and receipt of renal replacement therapy were associated with clinical failure. And this is not surprising results. Even with other drugs that have been studied, it seems that patients who have abnormal kidney function, they tend to fare less of a good outcome, perhaps because we jump into underdosing and adjusting the dose of the drugs. What about multinational observational studies? This was a prospective study, part of the CRACL consortium. This is run by the ARLG, or Antimicrobial Resistance Leadership Group, involving multiple centers, and we're part of this collaboration. And so they looked at patients who received Ceftazidime-avibactam and compared that to patients who received colistin. And as I mentioned, colistin had been overly used in the past for treatment of CRE infection. And compared with patients who received colistin, patients treated with Ceftazidime-avibactam, they showed a trend of being less likely to die, more likely to be discharged from the hospital within 30 days of initiation of therapy. They were less likely to die in the hospital and more likely to be alive, importantly, without renal failure. And when they did the analysis of the efficacy, the adjusted probability of better outcome of Ceftazidime-avibactam with colistin compared to colistin was 64%. So patient did better and, importantly, less renal problems. What about real-world evidence for OXA48 CPE? This is a single-center prospective observational study, 57 patients, again, majority being Klebsiella pneumonia, and 81% of the patients received monotherapy, some of them because they received Ceftazidime-avibactam because of previous treatment failures, other because they had absence of adequate treatment option or they had toxicity from previous treatment. And the clinical cure was achieved in 77% of the patient. The microbiological cure was achieved in 65% of the patient, respectively. 2 patients developed AKI during Ceftazidime-avibactam, which is really a lot lower than what you expect with a treatment such as colistin. What about data on hematological malignancies? Not a lot has been published on this, the evidence of Ceftazidime-avibactam in hematological malignancy, but this is just one report looking at a small number of patients, mind you, only 31 patients, but what it showed that the overall mortality of the patient treated with Ceftazidime-avibactam was 45%. Now, obviously, you can think about this as the bacteremia with CRE in patients with hematological malignancy tends to be associated with very high mortality, and we see that in practice. So again, the conclusion is with the lukewarm message, maybe an effective treatment because, again, limited number of patients, but at least this is something to consider. And the latest publication on the real-world evidence comes from the CAVICOR study, which is a multi-center study from the Spanish group. This is a retrospective observational study, but it looked at the large number of patients, 189, who received Ceftazidime-avibactam, and 150 patients received best available therapy. And how do we define BAT is according to the physician, what they thought, in clinical practice, BAT can be different from one center to the other. And so Klebsiella pneumonia was the most common. And again, in here, 70% of the patients who received Ceftazidime-avibactam received it as monotherapy. And when they did their analysis, the patient who received Cazavi had a lower 30-day mortality, 13%, as opposed to best available therapy, which was mortality of 22%. And so Ceftazidime-avibactam was thought to be the only independent predictor associated with improved clinical and microbiological response in this study. Now, what about the question of combination therapy versus monotherapy for KPC producers? And, when we use the older drugs in many serious infections for CRE, we tend to combine a couple of antibiotics, be it extended diffusion of carbapenem plus colistin or plus aminoglycoside or tigecycline, etc., for various infections. And this is data from Mario Tombarello from the Italian group, looking at retrospective multi-center study of a large number of patients, 577 patients with bloodstream infection, but also with non-bacteremic infection who received Ceftazidime-avibactam for KPC infection. And as you see here, the all-cause 30-day mortality rate was 25%, but there was no statistically significant difference in mortality among patients who were treated with Ceftazidime-avibactam alone and those who were treated with combination regimen, whether it was for bloodstream infection, respiratory tract infections, urinary tract infections, or others. So I think now that we have the novel drugs available to us, perhaps we don't have to use combination therapy. And when they looked at 30-day mortality and the factors that independently were associated with mortality, it was not one of them was not the fact that the patient received combination versus not. It was septic shock, neutropenia, lower respiratory tract, a high increment score, or again, those who had the dose adjusted for renal problem. Now, what about if we compare head-to-head Ceftazidime-avibactam versus Meropenem-vaborbactam, again, both being currently the potent anti-KPC drugs. this is a multi-center retrospective cohort study, patients who received more than 72 hours with either agent. They excluded patients with only UTI because these tend to be less sick patients. 131 patients were included, and as you see, the demographics and patient characteristics were not that different. And if we compare the two arms, as you see here, there was no significant difference in the clinical outcome, whether we look at clinical success or number of failures. Perhaps the only small difference is the number of emergence of study drug resistance, 3 reported in the Ceftazidime-avibactam arm versus none reported in the Meropenem arm. So if we look at the data from Pittsburgh on the left side, or the North Carolina, Florida experience on the right side, as we see both Ceftazidime-avibactam and Meropenem-vaborbactam are really similar in terms of activity. And again, just the emergence of resistance tends to be more of an issue, although the rates are quite low still with Ceftazidime-avibactam. Couple of words on other CREs, metallo-beta-lactamases. As you know, not a lot has been published so far, but I think now, based on an earlier report, it became the practice that aztreonam combined with Ceftazidime-avibactam is what people are using for metallo-beta-lactamase treatment. This is again from Italy, from Falcone's group. They looked at 102 patients with bloodstream infection due to metallo-beta-lactamases, 82 NDM, 20 VIM, 91% were Klebsiella pneumonia. And if we compare the 30-day mortality of the patient who received Ceftazidime-avibactam to the other regimens, including colistin regimen or non-colistin regimen, which could include fosfomycin, tigecycline, aminoglycoside, the mortality is much less with the combination Cazavi and aztreonam. Now, we cannot talk about an antibiotic without mentioning resistance, because from this graph below, every antibiotic that has been discovered, some of them within years, some of them within much longer time, ultimately antimicrobial resistance would develop. And so for Ceftazidime-avibactam, I shared with you some reports suggesting that some resistance can develop, but it has been, in all reports, less than 10% of patients who have received it. And the mechanism is predominantly due to mutation in the KPC3 omega loop. And this is the mutation in red here, the substitution, which is the most common. Interestingly, though, when the isolates become resistant to Ceftazidime-avibactam, they regain susceptibility to carbapenem. And so this is something that the Spanish group, Rafael Cantons and others have really described at length. So what have we learned from real-world studies? I think we have learned that we need to consider the patient's comorbidities and the local resistance in terms of trying to decide what to give for empirical therapy. We need to include our new drugs in our treatment choices and not leave them on the shelf to only use them when we fail therapy. I think if we look at the IDSA guidelines and the very recent ESCMID guidelines that were published last year, in both of them they say avoid colistin in the treatment of carbapenem resistance in Enterobacterales whenever you have other options. Now, granted, some of the drugs are not available in all countries and they're still using these drugs and continue to observe quite a bit of toxicity. And whenever we have access to molecular diagnostic tools in the hospital, I think that could help guide our therapy because, as I showed you, not all drugs that are available works against all carbapenemases. And if I have to reflect on what would be my treatment of choice depending on the type of carbapenemase, I think, though we don't have much still real-world data on Meropenem-vaborbactam, I think for KPC, it's Meropenem-vaborbactam. If it's available, definitely Ceftazidime-avibactam. For NDM, perhaps still now the first choice is Ceftazidime-avibactam plus estrionam until we see more publications from other drugs being used. For OXA48, Ceftazidime-avibactam. And as you know, there are some Carbapenem resistance in Enterobacterales that is due to other mechanisms and not carbapenemase production, and in those we really have to be guided by your in vitro susceptibility. And there are some remaining gaps in the literature. We really need to see more real-world evidence from the other drugs that are currently being used in some countries to really establish their role in the treatment of CRE and compare these other agents for mono versus combination therapy. I'm going to stop here and I'll be happy to answer any questions you might have. Thank you.